Yeah, good afternoon, everyone. So today I'll be speaking on vascular complications in small children, how to deal with. So all the interventionists, how trained we are, we're always will be having some vascular complication, especially in infants less than 10 kg babies. So the complications, the reported complications are 1 to 40% in different papers. And permanent arterial loss is around 5 to 20%. The known complications are groin hematoma, vessel disruption or rupture, vessel thrombosis or vessel spasm, retroperitoneal hematoma, pseudoaneurysm, especially in adults, and arteriovenous fistula, and limb loss. We have encountered one such case. Groin hematoma is a common complication if after sheath removal we are not properly holding the artery, then after some time we will have hematoma, and sometimes we will encounter pseudoaneurysm because of improper pressure application on the puncture site. Retroperitoneal hematoma mostly because of inadvertent rupture of the artery, mostly femoral or iliac artery. Then it may cause retroperitoneal hematoma. So this is one example. This slide I took from Dr. Amitabh Chattopadhyay. So this is a iliac artery rupture, and you can see from the other side also we are injecting. So after just inflating a balloon for some time, this rupture, it was okay. Then the patient went home. Vascular spasm, many times we have seen the vessel spasm, we are not able to negotiate the catheter, or sometimes are not able to pass the sheath, femoral sheath. And sometimes we have given GTN to these vessels from the other side and it is opened up. So how to deal with it? These are the checklists from a paper by Dr. Sack and Dr. KK. Actually, if we take care regarding the puncture, like local anesthesia, we all know all about this, but I have to stress upon regarding the ultrasound guided puncture. So nowadays in smaller kids, ultrasound guided puncture will give less complication. And before that, we have to understand the anatomy. Most of us, while we are busy in doing the intervention, we are forgetting where to puncture exactly. If we are puncturing lower down, sometimes you may cut the saphenous vein. In femoral vein, we are doing femoral vein access. Or in artery also, if you are puncturing lower down, the blood will come, but will not be able to negotiate the wire because we may pierce the profunda femoris or superficial femoral artery. The inguinal ligament 3 centimeter or 1 finger down the inguinal crease. So that is the most crucial part we have to do our puncture. And the other vascular access like IJV access or common carotid, nowadays, lot of interventions we are doing through carotid access for ductless stenting. I have gone through the papers. They are saying even the carotid artery is more roomy than the femoral artery in smaller kids. So we can do the procedure. One paper I saw, they have done around 17 cases and without any complication, minor, maybe this is, they're saying vascular access must be done under ultrasound guidance and the posterior wall of the carotid artery should not be punctured. Then we can do it percutaneously. Axillary artery access, most of us doing the vertical PDA, we are using this axillary access, mostly the third part. The part 1 is after the first rib and below the pectoralis minor is the second part. The third part, there is no branches. We can negotiate the sheath nicely. But recently we had one complication. This is the vascular probe we are using nowadays. The left one is the G probe and the right side one is the Phillips probe. This is in our lab, first identifying the axillary artery. Then you have to poke the syringe or a cannula. Here, right side, you can see the cannula is just entered the vessel. And after that, you can put the wire, guide wire. So this is after the sheath removal. This axillary artery, we had a small kid, 4 kg. There was a pseudoaneurysm confirmed by the ultrasound sonography. And we had to send this kid to surgery. And after surgery, there was good flow in the axillary artery. Femoral vein access, as we have already told, just near the inguinal crease, we can put the vascular probe and we can identify the artery, both the artery and the vein. Then we can access easily. So just poking, and we can see the needle is entering to the femoral vein here. And we will see a gush of blood in the needle hub. One case I'm sharing is our case. We are doing the BPV and the balloon got ruptured. Then by pulling the balloon, inadvertently we pulled the sheath. The the groin sheath had came out. And then finally, after pulling for a long time and trying to negotiate it, we just passed a wire. Then from the other side of the groin, we try to catch hold of the tip and pull it back, but we were unable to do that. We were not able to reach the balloon. So then we had to send this patient for surgery. And we cut the balloon shaft and sent the patient for surgery. Then finally we found there was a transverse fracture in the balloon, and that's why it was not coming into the sheath. And so we are unable to catch it from the other side also. After surgery, the child is doing well now, no issues. Most commonly, we found arterial pulse loss, and our institutional practice after sheath removal, after 1 hour, we start heparin, 10 to 20 units per kg per hour. And this paper says 2 to 3 hours after the procedure, we can start heparin. And loading dose, some people give, but most of us, they don't practice loading dose. Directly, we can give heparin infusion for 24 hours. If there is no return of pulse, then we can thrombolize. So streptokinase, I have used one of my case. There was femoral vein thrombosis after PDA device closure. Then I got excellent result in that. Alteplase, we can use 0.7 mg per kg. And then loading, then followed by the infusion 0.2 mg per kg per hour. The endpoint is return of pulse, bleeding at the entry site, and if there is internal bleeding or hematemesis, melena or cerebral hemorrhage or retroperitoneal bleed, we have to stop it. And if no response after 6 hours, or if there is clinical deterioration, we can stop this. So the complications, they are more common if we are dealing with the arterial side. Vascular complications are mostly the BAV or balloon coarctoplasty in small kids. And suppose we are doing VSD device closure in smaller kids, then also we have to take care of the sheath. And mostly I have found if we are using a smaller sheath, the sheath, what exactly required, we should take that sheath only. Thermos sheath and the Cook sheath, both are nice. But smaller kids, I prefer thermos sheath. And if you're upsizing the sheath, suppose 4 French to 5 French, one paper I found the complication increased from 5.5 to 12.9. And if you are upsizing it to 6 French, then the complication, the chance of arterial blockage is 42%. One paper has shown if the ACT we are maintaining more than 200, then there is less chance of thrombosis, but other papers have shown this is insignificant. Even if you are maintaining 200 ACT, more than 200 ACT, still you will get the thrombosis. So to summarize, arterial occlusion will be more common in young children and longer procedure time or difficult access. So in those cases, high-risk cases, we can anticipate there is some occlusion, there will be arterial pulse loss. So we can anticipate, we can start heparin. Use of low profile balloon. This is a good technique when we are using, suppose we have to take a bigger balloon. Now, of course, we are using low profile balloon, Tysac balloon, we are using, but other cases, suppose we are using, we have to use higher frequency balloon, we can take double balloon. Early institution of heparin in small infants and judicious use of vasodilators, like as I have told, we have used IV GTN for vascular spasm, and USG guided access. It's most important nowadays in smaller kids. We have to do some practice on it, and after a few cases, we'll get the expertise. Then you have to have the surgical backup in bad cases. Thank you.